what if adding aspirin to your anticoagulated cardiac patient is actually killing them? The AQUATIC trial just turned conventional wisdom on its head, and every clinician needs to know these results. Today, we're breaking down this game-changing study published in the New England Journal of Medicine in August 2025 that's forcing us to rethink how we manage some of our highest-risk cardiac patients. Here's the clinical dilemma. About 15% of patients with chronic coronary syndrome also need long-term oral anticoagulation, usually for atrial fibrillation. Historically, we've been taught that antiplatelets prevent coronary stent thrombosis and anticoagulants prevent stroke from AF. When both conditions coexist, many clinicians have defaulted to using both medications, the so-called dual therapy. But here's the problem. This combination significantly increases bleeding risk. And previous trials exploring this question were open-label, enrolled predominantly low-risk Asian populations, and gave us conflicting results. So the question remained, should we be routinely adding aspirin to anticoagulation in these high-risk patients with coronary stents? That's exactly what AQUATIC set out to answer. Before we go further, let's quickly define chronic coronary syndrome, or CCS. This term replaced what we used to call stable coronary artery disease. It's a spectrum of clinical presentations arising from myocardial ischemia, usually due to coronary artery or microcirculatory dysfunction. Symptoms are typically provoked by exertion, emotion, or stress. CCS affects about 1 in 20 adults worldwide, and over half may have what we call ANOCA or ENOCA. That's angina or ischemia without obstructive coronary arteries. This highlights that coronary disease isn't just about big blockages. Microvascular dysfunction plays a huge role too. Here's the central research question for AQUATIC. Does adding aspirin 100 milligrams daily compared to placebo improve outcomes for patients with chronic coronary syndrome who have a coronary stent in place and are already on oral anticoagulation? Notice the specificity here. These are patients more than 6 months out from their stent placement, so we're in the chronic phase, not the immediate post-PCI period. Let's talk methodology. AQUATIC was a multi-center, double-blind, placebo-controlled, randomized trial, the gold standard design. It enrolled 872 adults from 51 centers across France. The original target was 2,000 patients, but the trial was stopped early. We'll get to why in a moment. Inclusion criteria were strict. Patients had to have undergone coronary stent implantation more than 6 months prior, be at high atherothrombotic risk, meaning they had features like diabetes, chronic kidney disease, peripheral artery disease, or multivessel disease, and they had to be on oral anticoagulation for any reason, though predominantly for atrial fibrillation. The trial ran from May 2020 to April 2024, with a median follow-up of 2.2 years. Patients were randomized 1-to-1 to receive either aspirin daily or matching placebo while continuing their background anticoagulation. On average, the patients were 72 years old, 85% male, which is a limitation we'll discuss later. 37% were diabetic, 69% hypertensive, and remarkably, 72% had a prior myocardial infarction. The median time since their last PCI was 3 years. 89% had atrial fibrillation, and nearly 90% were on direct oral anticoagulants, with only 10% on warfarin. This is a genuinely high-risk cohort, exactly the population where you might expect aspirin to provide benefit if it were going to work anywhere. The primary outcome was a composite of cardiovascular death, myocardial infarction, stroke, systemic embolism, coronary revascularization, and acute limb ischemia, a comprehensive measure of major atherothrombotic events. Key secondary outcomes included net adverse clinical events, which adds major bleeding to the atherothrombotic events, all-cause mortality, and major bleeding. The statistical approach was robust. Intention to treat analysis using Cox frailty models adjusted for randomization strata, with hierarchical testing for secondary outcomes. Now for the results. And they're striking. The primary composite outcome occurred in 16.9% of the aspirin group versus 12.1% in the placebo group. That's a hazard ratio of 1.53 with a p-value of 0.02. In other words, aspirin increased the risk of major cardiovascular events by 53%. All-cause mortality and cardiovascular death was also increased by 72% and 90% with aspirin, nearly double the risk. Hazard ratio was 1.85 for net adverse clinical events, combining death, atherothrombotic events, and major bleeding. Let that sink in. Aspirin didn't just fail to help, it actively harmed these patients. The Data Safety Monitoring Board rightfully recommended stopping the trial early due to excess deaths in the aspirin group. The bleeding results were equally dramatic. Major bleeding by ISTH criteria occurred in 10.2% of aspirin patients versus just 3.4% on placebo. More than a threefold increase in major bleeding with a hazard ratio of 3.35. Hazard ratio for any bleeding was 1.97. Using TIMI bleeding criteria, the number was even more stark, hazard ratio 3.68. But here's a critical finding. Stent thrombosis was extremely rare, only one event in each group, or 0.2%. This tells us that oral anticoagulation alone provided adequate protection against stent thrombosis, even in this high-risk population. The bleeding likely contributed significantly to the excess mortality observed in the aspirin group. Let's critically appraise this study. What were the strengths? First, rigorous design. This was double-blind and placebo-controlled, unlike previous open-label trials, that minimizes bias from physician behavior, patient expectations, and outcome reporting. Second, high-risk population. 100% had prior stenting, 72% had prior MI, and the event rate was 7 to 8 times higher than in previous trials. This is exactly the population where aspirin should theoretically work if it's going to work anywhere. Third, clinical relevance. This was a European cohort. All types of oral anticoagulants were allowed, and it reflects real-world practice much better than previous Asian-only or single-agent studies. What about limitations? The trial was terminated early, enrolling only 872 of the planned 2,000 patients limits statistical power for subgroup analyses, though the consistency of harm across all outcomes is reassuring. Generalizability was limited as well. This was a single-country study from France, and women were markedly underrepresented at only 15% of participants. We need to be cautious extrapolating these findings to female patients. Mechanism remained unclear. Why did cardiovascular mortality increase beyond just bleeding? The specific causal pathway needs further investigation. Timing specificity was also an issue. Patients were enrolled more than 6 months post-PCI. This trial doesn't address the optimal strategy in the immediate post-stenting period, which remains an open question. The message is crystal clear. Oral anticoagulation alone is the preferred strategy for chronic coronary syndrome patients more than 6 months post-stenting who require long-term anticoagulation. Adding aspirin causes net harm, increased death, increased cardiovascular death, and significantly increased major bleeding. Even in patients at very high atherothrombotic risk, stent thrombosis risk is extremely low with oral anticoagulation alone. These findings strongly support current European and American guideline recommendations to discontinue antiplatelet therapy beyond the early post-PCI period in anticoagulated patients. This should fundamentally change practice. The number needed to harm with aspirin in this trial was approximately 21 patients for the primary outcome and just 15 for major bleeding. Extrapolated globally, continuing aspirin in this population could cause tens of thousands of preventable deaths annually. So this is the bottom line. In patients with chronic coronary syndrome at high atherothrombotic risk requiring long-term oral anticoagulation, adding aspirin at more than 6 months post-stenting significantly increases mortality and bleeding without reducing ischemic events. OAC monotherapy should be the standard of care. The AQUATIC trial, combined with previous studies like AFIRE and OAC alone, provides robust multinational evidence against dual pathway therapy in the chronic phase of coronary disease. This is a practice-changing trial. If you have patients currently on both aspirin and an oral anticoagulant who are stable and more than 6 months post-PCI, it's time to have a conversation about stopping the aspirin. But here are 2 questions we should keep thinking about. First, should these findings change practice immediately for patients currently on stable dual therapy beyond 6 months post-PCI? Second, what is the optimal duration of dual pathway therapy in the immediate period after PCI in patients requiring anticoagulation? That's the window from PCI to 6 months that AQUATIC didn't address. If this video helped clarify the AQUATIC trial for you, please give it a thumbs up and subscribe for more evidence-based Journal Club content. Drop your thoughts in the comments. Are you already changing practice based on these results? I'd love to hear from you. Thanks for watching, and remember, always practice evidence-based medicine.